everyone, and welcome to the Lung Health Foundation Pediatric Asthma Webinar Series. My name is Lana, and I'm a respiratory therapist, certified respiratory educator, and curriculum developer for the Provider Education Program at the Lung Health Foundation. In February 2020, Ontario Lung Association became the Lung Health Foundation. At the Lung Health Foundation, we are dedicated to ending gaps in prevention, diagnosis, and care of lung disease in Canada by driving groundbreaking research and giving our patients and their caregivers, as well as healthcare providers, the programs and support they need. This Pediatric Asthma Webinar Series was created specifically to address gaps in knowledge and training regarding diagnosis, risk factors, and appropriate management of asthma in children and youth. Today in our audience, we have respiratory therapists, nurses, family physicians and physician assistants, nurse practitioners, and many other healthcare providers. Quick reminder for family physicians, all webinars in this series are certified by the College of Family Physicians for the total of 6 main Pro Plus credits. So today we're kicking off our series with a presentation by GINA Radhakrishnan. How do we manage childhood asthma? Introducing the Ontario Health Asthma Quality Standards for children and adolescents. Just before I introduce our speaker, please note that this presentation will take approximately 40 minutes with approximately 10 minutes in the end for your questions. Please use Q&A feature on the bottom of your screen to submit your questions to Dr. Radhakrishnan. It will also be recorded and posted on our website under Education for Healthcare Providers. So now it is my pleasure to introduce Dr. Radhakrishnan. Dr. GINA Radhakrishnan has completed her medical training, including a fellowship in pediatric respirology at the University of Toronto and Hospital for Sick Children. In 2010, she joined the Western University in London, Ontario, as an assistant professor of pediatrics and led the development of multidisciplinary asthma clinic at the Children's Hospital at London Health Science Centre. Her clinical research interests include childhood asthma and cystic fibrosis, as well as clinical epidemiology. Dr. Radhakrishnan joined the Children's Hospital of Eastern Ontario, or CHEO, and University of Ottawa in 2015, where she is currently the director of the CHEO asthma program. Welcome, Dr. Radhakrishnan. Go ahead.
Thanks very much, Lana, for that introduction. And thank you, everyone, for tuning in on your lunch hour to learn or hear or refresh yourselves a little bit about childhood asthma. And the focus of my talk today is specifically around the Ontario Health Asthma Quality Standards for children and adolescents, which were just published 1 month ago and are available online. For some reason, I'm having difficulty. Oh, there we go. So just in terms of disclosures, I think I skipped a few here. I will reveal that I was co-chair for the Health Quality Ontario Asthma Quality Standards Advisory Committee. I am a speaker with the Lung Health Foundation. I'm a member of the Canadian Thoracic Society, and I have received research grant funding through a few organizations in Canada and Ontario. This pediatric webinar series has received financial support from the Ministry of Health, but there are no specific conflicts of interest identified. And in terms of mitigating potential bias, there are a number of strategies and items listed here, which I won't read in detail, but are available for you to look at. So moving right along, at the end of the session, in terms of objectives, I would hope that participants would be able to demonstrate knowledge of the goals and process for the development of quality standards at Ontario Health, formerly Health Quality Ontario, recognize opportunities for change and improvement in the care of children and adolescents with asthma, and apply the 6 Ontario Asthma Quality Statements for children and adolescents with asthma within your own practice. So why is it important to develop quality standards for asthma? Well, if we look at some data in the province of Ontario from 1996 all the way through 2016, and this data is courtesy of Dr. Teresa To, who leads the Ontario Asthma Surveillance Information System, or OASIS, which tracks the burden of asthma in our province. We can see that over the last 2 decades, there has been a steady decrease in new cases of asthma or asthma incidents. But the prevalence of asthma, the total number of asthma cases, continues to remain high. And of all the people with asthma, we estimate that about 50% probably have uncontrolled asthma. And amongst those with uncontrolled asthma, that could include people who have mild asthma and moderate asthma, and some people up to 5% who in fact truly have severe asthma. But what does uncontrolled mean? It refers to poor symptom control. So people who continue to have symptoms, people who have frequent and severe exacerbations, for example, 2 or more courses of systemic corticosteroids per year, people who have had serious exacerbations, which would imply 1 or more hospitalizations per year, or people who have airflow limitation. And that means when we measure their lung function, their forced expiratory volume in 1 second is less than 80% of their personal best, or less than the lower limit of normal. So this is morbidity that we would like to avoid, and there are options for improving asthma control and reducing this level of morbidity. Now, there's quite a bit of regional variation across the province of Ontario in terms of asthma morbidity. And if we look at one measure of this, which is asthma hospitalization, on the left of your screen, we have represented all the different local health integration networks. And again, this is dating back to 2016 when we were using LINS as a geographical measure. And on the y-axis, the vertical axis, we have the percentage of people hospitalized in a given year in each of those LINs. And as you can see, there's quite a bit of variation when this has been normalized across the province. Really, there's no clear reason that this level of variation should exist, and it makes one think that there's likely practice variation or differences in the way that asthma is managed in these different regions that actually leads to this variation. If we then look at specifically the breakdown of the ages of people hospitalized across Ontario, we can see that the group that is most vulnerable is really very young children, or children 0 to 4 years of age. And then we see another spike above the age of 70. But today's talk, of course, will focus on children. So how can we ensure good quality care for people with asthma, especially given there's so much practice variation and regional variation in morbidity? One way is to develop quality standards. And I'll just read out to you all the different goals that quality standards could help achieve. Quality standards can help patients, families, and caregivers know what to ask for of their healthcare providers in their care, how to advocate for the best care. These can help healthcare professionals know what care to offer based on evidence and expert consensus opinion. Quality standards can help healthcare organizations measure, assess, and improve the quality of care they provide. And quality standards can help ensure consistent, high-quality care right across the province. So in response to this notion that there's a high burden of asthma, morbidity across the province, and regional variation, the Ontario Health Group decided that asthma was a good target area for the development of quality standards. And to effect this, in the summer of 2018, they convened an advisory committee of 21 individuals. These individuals were geographically dispersed across Ontario and representative of many different clinical health disciplines, as well as people with lived experience or patients with asthma and important stakeholder organizations. The committee was chaired by Dr. Samir Gupta and myself. And the process, in a very quick nutshell, but I will go through it in more detail, was to first set out, and perhaps some of you on this call today received, a request for information, feedback, prioritization areas that people feel would be important to target in the development of quality standards. We then reviewed evidence summaries that had been prepared by the Health Quality Ontario Committee, specifically Canadian and global guidelines in the management of asthma. There were 5 formal video conference committee meetings, and then several additional informal meetings between just the co-chairs and the core staff. And we then put out these draft statements for stakeholder input in the summer of 2019. And again, this may have been an opportunity that some of you participated in. Now, just a little, is it humor? I'm not sure, but it's funny for me to think that when we did this back in 2018 and 2019, we did use video conferencing for these 5 meetings and all of the subsequent meetings, but this was of course pre-pandemic, and it's funny to think that that's all life means now. If we say meeting, it obviously means virtual. Anyhow, continuing on. So what did we actually do in the very first meeting? Well, this one was to make decisions about the scope of the standards, the setting in which they would apply, and the ages in which they would apply. As far as setting, the group decided, and this was all through discussion, sometimes even voting, but we decided that the setting would be primary care. And the reason for that is that there were already recently developed position statements and recommendations for practice, specifically for the inpatient setting, the emergency room setting, and in the context of severe asthma in the province and in Canada. So we chose to really focus on primary care. The age groups that we decided upon based on the types of symptom burden and the types of therapies and treatment approaches that are recommended, these were divided into children and adolescents, 1 to 15 years of age, and then adults, 16 years of age and older. During meeting 1, we identified the priority areas that we wanted to try to improve as far as asthma care in the province. And we had received some 15 to 17 different potential priority areas and whittled these down through voting to just 6 topics, which in brief include the following. So asthma diagnosis, and this was combined with identifying comorbidities in a patient. Patient education and self-management, which would include smoking cessation. Pharmacological management, monitoring asthma control, referral to specialist, and follow-up after discharge. During meetings 2 and 3, we then rolled up our sleeves and did the heavy work of drafting the quality statements, basically turning the 6 priority topic areas into concise, evidence-based statements that would describe high-quality care. That was the goal. We also provided feedback to the core committee on the definitions that would explain the key components included in the quality statements. And we also fed back on the types of quality indicators that would help measure success in implementation of these statements. Now I'm going to go into all of this in much more detail, and what I'm talking about will become quite clear. So this is what the asthma quality standard looks like. And as mentioned, it was just published online last month. So when you open it up, you see the quality statement itself, and there are statements 1 through 6. And just below each of the statements is a set of definitions. And in addition to definitions, there are then reworded statements, or the statement reworded specifically targeted to certain audience. So to clinicians, to health service planners, and to patients. So the asthma quality statements, let's dive right in. And this is the website where you can access them. But certainly if you were to type in search terms such as asthma quality statements Ontario into your web browser, you would be able to pull these up quite quickly. So quality statement 1, diagnosis of asthma. And the statement reads, children 6 years of age and older and adolescents clinically suspected of having asthma complete spirometry to demonstrate reversible airflow obstruction, and if negative, other lung function testing to confirm the diagnosis of asthma as soon as possible. Children 1 to 5 years of age are diagnosed with asthma after documentation of signs or symptoms of airflow obstruction, reversibility of symptoms with asthma medication, and no clinical suspicion of an alternative diagnosis. So you'll notice in this statement, and again, the wording is very precise, every word went through voting and discussion if there was any hint of controversy, and the attempt very much was to align with our Canadian Thoracic Society guidelines, and when guidance was not available at our national level, to look to global guidelines. So in this statement, we emphasize spirometry as being a way to objectively diagnose asthma. And we've included this sort of vague time frame of as soon as possible. And I'll talk to that a little more in this next slide. So for the diagnosis of asthma, is spirometry really required? Well, the quick answer is yes, if possible. And why is this? Underdiagnosis of asthma leads to undertreatment of asthma. And this is detailed in a publication by Sean Aaron and Andrea Gershon in 2017. Undertreatment can happen, or underdiagnosis, in 20 to 70% of people, and overdiagnosis can lead contrarily to overtreatment in 30 to 35% of people. Now, preschoolers are a little more tricky because it's difficult to perform spirometry in them. So that's why the diagnosis of asthma in this age group has been pulled out separately and is intended to be based on an algorithm which aligns nicely with the Canadian Thoracic Society position statement for the diagnosis of asthma in preschoolers. But for adolescents and children 6 and older, really we should be doing spirometry to confirm the diagnosis of asthma. So that would be spirometry with bronchodilator testing. But if that's negative, to then move forward with bronchoprovocation testing, specifically methacholine testing or exercise provocation testing to confirm a diagnosis of asthma. So then what about timing? What does as soon as possible mean? Well, if you read through in the detail of the quality statement 1, really what we mean is within at most 3 months. So the idea is that as soon as you suspect a diagnosis of asthma, really a request for spirometry or objective testing should be made, and hopefully this will be completed within 3 months of seeing that patient and suspecting asthma. But while waiting for that spirometry to be done, we have included, and I would emphasize, especially in the current pandemic time where wait times for achieving spirometry are much, much longer than they were this time last year even. We really should consider a trial of medication while waiting for objective diagnosis, and that is to avoid delays in treatment, particularly for patients who are susceptible to exacerbations or currently have poor asthma control and are suffering with poor quality of life or symptoms that prevent them from participating fully in their activities of daily living. When this particular statement was put out for public feedback in the summer of 2019, really the pushback was around lack of resources to perform pulmonary function testing, both in adults and certainly in children. And in reality, current wait times for spirometry may be in excess of 3 months. But really, that's the whole point of putting together these standards for what quality in asthma diagnosis and treatment mean. The intent is not just to inform care providers and patients, but also healthcare funders, people who organize and resource our healthcare system so that we can inform them where that allocation should happen. And certainly spirometry is one of these areas. So moving right along to quality statement 2, which speaks to asthma control. Children and adolescents with asthma have a structured assessment at least annually to determine their level of asthma control and reasons for poor control. So what is the right frequency for assessing asthma control? And what would structure assessment mean? So structured assessment can include using validated questionnaires as well as spirometry. Some of the questionnaires that can be used in the childhood age groups include what's called the Asthma Control Test or the Asthma Control Questionnaire. And these questionnaires are available free of charge online and can be accessed easily by care providers. But we can also use our Canadian Thoracic Society guidelines, which include an assessment of asthma control or the parameters of asthma control. And these would include daytime symptoms occurring less than 4 days a week for children 6 and older, but less than 2 days a week for the preschool age group, less than 6 years. Nighttime symptoms happening less than 1 night per week. Rescue medication needed less than 4 times a week, so 4 doses per week for older children, and less than 2 days a week for preschoolers. Physical activity should be normal. And this type of structured assessment should happen at least annually at every asthma visit, after a severe exacerbation, and after any change in treatment. We also included that if an individual, a patient, is using more than 3 canisters of their short-acting beta agonist per year, that is an indication of poor asthma control and when perhaps a treatment change should be made. So moving along to quality statement 3, asthma medication. Children and adolescents with asthma receive appropriate medication and devices based on their age and current level of asthma control, including early initiation of regular inhaled anti-inflammatory therapy. So by regular, what we really mean is daily, and there's quite a bit of discussion whether to include that word daily or not. And in a moment, it will be clear why we chose not to include that in the wording, but it is included in the definitions. And by anti-inflammatory therapy, for the most part, we mean low-dose inhaled corticosteroids. So when we were very close to completing the drafting of these 6 quality statements, in fact, finalizing the wording, then in the spring of 2019, the new Global Initiative for Asthma, the GINA guidelines, came out. And in those guidelines, there was a big change in the recommendations for how we should approach asthma, including in people with very mild asthma. And really, GINA recommended that treatment of asthma with a short-acting beta agonist alone would no longer be recommended. In fact, just to break this down further, in people with very mild asthma, so less than 2 symptoms or 2 days of symptoms a month, this would be called step 1 in the GINA guidelines. The recommendation would be to treat individuals with low-dose inhaled corticosteroid formoterol, so a LABA medication as needed, long-acting beta agonist plus inhaled steroid as needed. In step 2, which would mean people who have symptoms more than twice a month, plus risk factors for asthma exacerbation, the treatment recommendation by GINA is to use daily low-dose inhaled corticosteroid and as needed short-acting beta agonist or low-dose inhaled steroid formoterol as needed. And this is where we had difficulty within our group deciding whether to use that word daily in the asthma quality statement or not, because as you can see, we had a global organization, a well-respected one, GINA, suggesting that in certain individuals, as needed inhaled steroid plus formoterol may be appropriate for managing asthma. And all of this is based on some publications that came out in 2018 and 2019, prominent publications, large randomized controlled trials in the New England Journal of Medicine, comparing as needed budesonide formoterol, so one version of an ICS LABA medication, in mild asthma, and in comparison in one of these studies to maintenance budesonide or maintenance daily inhaled corticosteroid. And these studies did suggest that as needed budesonide formoterol might be just as effective for reducing exacerbations in people with mild asthma as daily inhaled corticosteroid. So again, this is a huge change in the way we had been managing asthma up until now. So the question is, what are we supposed to do for this? I see there's a question here. If you don't mind, I'm going to get to questions at the end. We should hopefully have enough time. So in 2019, in response to the GINA statement, the Canadian Thoracic Society published this position paper, which was really a question and answer format in conversation with Dr. Helen Riddell, who is the chair of the GINA Scientific Committee. And a number of questions and responses were provided around how is the GINA recommendation relevant to the Canadian context, and should it even be applied or integrated here? Now, I will say, in addition to this position statement, the CTS has actually developed a formal guideline specifically to answer this question in the Canadian context. And that guideline should be getting released next month, probably towards the end of November. So stay tuned for that. So moving along to quality statement 4, self-management education and asthma action plan. Children and adolescents with asthma and their caregivers receive asthma self-management education and a written, personalized asthma action plan that is reviewed regularly with a healthcare professional. So what should be included in asthma self-management? And what is the right frequency to review an asthma action plan and provide self-management education? So self-management education and action plans really should include all of the following. When we say asthma education, we often automatically think puffer technique, but really there's much more to it than that. And the components should include assessment of adherence. So not just correct technique, the right delivery device for administration of the medicine, but how often it should be used, and emphasis that when prescribed as such, it really should be used every day. Education also includes identification and avoidance of triggers. This becomes particularly important in the context of children when there's more than one home where the child resides, weekends with one parent, weekdays with another, as an example, and there may be different triggers and allergens and irritants present in the different homes. There may be other care facilities that the child attends, daycare, school, and in the context of adolescents, even that 12 to 15 year age group, there may be after school jobs, babysitting jobs, where the child may be exposed to different triggers. So it's important to do a thorough review and ideally plan for avoidance of triggers. Smoking prevention and cessation, both in the patient, him or herself. Certainly, unfortunately, adolescents may themselves smoke, but certainly also in their caregivers in the homes and settings that they reside in. Identification and management of comorbidities, for example, allergic rhinitis, and often we partner with allergy specialists to identify these types of comorbidities. And then, if indicated, reviewing the peak flow meter and how to use it. This would be for older patients, specifically adolescents in most cases. Now, in terms of the technique, though, how do we use these inhaled medications? What devices to use? The Lung Health Foundation has several videos available on their website, which I've listed here. And I am a physician at CHEO, and I will put a plug to say that CHEO asthma website also includes a link to the Lung Health Foundation one's videos on how to use asthma inhalers. And this, again, during the pandemic time, has become increasingly well-received resource for families to have videos on how to use medications, because it's difficult to always bring families in person to review this kind of technique. And this is a resource that's available very easily for community care providers. And how often should we be doing the self-management education and review of asthma action plan? Well, really, it should happen at least once a year for someone with asthma who is on asthma medications, but at least in addition to that, after every asthma visit, after a severe exacerbation, so anytime the patient has required oral corticosteroids, when there's a change in the level of asthma control or a change in treatment. This here is the Pediatric Asthma Action Plan that is now also available on the Lung Health Foundation website, and it is intended to be the action plan for our province. It, in the similar fashion that the asthma quality standards were prepared with multiple stakeholder feedback, multiple participants providing input, the Pediatric Asthma Action Plan was also developed in this systematic, rigorous fashion using the best evidence available to develop its content. And on the back, it's intended to really help with that self-management education. There's a section on triggers and how to identify and avoid triggers, emphasis on adherence. And then for care providers, there's also an algorithm for how to diagnose and manage asthma, specifically in the preschool age group. So we're getting to the end of the statements, a few more to go. Quality Statement 5, Referral to Specialized Asthma Care. So children and adolescents with asthma with appropriate indications are referred to specialized pediatric asthma care. Specialized pediatric asthma care doesn't necessarily mean a respirologist. It certainly could include an asthma educator, an asthma clinic, There are a number of PCAP clinics across the province, for example, a respirologist, a pediatrician, an internist, or an allergist. But what are appropriate indications for referral? Where there's a whole laundry list of them, and I am going to go through each of these. So for adults and children, some of the indications for referral would include when the patient is unable to perform spirometry, so making that objective diagnosis is difficult. Now, I will caveat by saying that it doesn't necessarily mean that every preschooler with asthma necessarily has to be referred. Again, there are specific guidance on how to make a diagnosis of asthma, specifically in the preschool age, which does not require spirometry. Excuse me. But certainly, if there's any diagnostic uncertainty, if there's need for allergy testing, we would recommend to refer to the appropriate specialist. If there's uncontrolled asthma, and in particular, if a child has had any asthma-related hospitalization, that is an indication to refer to specialist care. Personally, in my own experience, I feel that is the indication that is not as well addressed, perhaps, as some of the others. So I do want to, again, emphasize and alert everyone that if a child is hospitalized for asthma, they really should be assessed by a specialist. And again, that specialist may be a family physician who has an interest and particular expertise in asthma and is plugged in with other resources. It may mean a pediatrician, or it may mean another subspecialist, but really that child deserves a further look. If there is a diagnosis or a suspicion of severe asthma, there should be a referral. If there's a suspicion of work-related asthma, and again, this is not exempt to children because certainly adolescents can be working too, or if there are side effects of treatment. Other indications which may be a little more specific to children, but some may pertain to adults as well, would include if there's a comorbidity that requires specialist care, if there's lack of response to a medium dose controller medication, if there's been more than one severe exacerbation, so requiring oral corticosteroids, if ever there's been a life-threatening event like an ICU admission, if, despite efforts at the primary care level, the family or patient demonstrate poor understanding of asthma self-management, that may be an indication for referral where there may be additional resources available for the family to support them through managing their disease. If the child has persistent abnormal lung function, even if their symptoms seem to be well controlled or well managed, this may be an indication for referral. And finally, sometimes parents have significant anxiety, worry about the use of asthma medications. These could all be indications for referral as well. Quality Statement 6, follow-up after discharge. Children and adolescents who have had an emergency department visit or been hospitalized for an asthma exacerbation have a follow-up assessment within 2 to 7 days after discharge. So what should be included in this assessment, and why have we chosen this time frame of 2 to 7 days, which in some cases may seem too short, it may seem too long, but this is how we arrived at it, because there's actually very little evidence or literature about this, and it really ended up being consensus and coordination that drove this decision. So first of all, it's important to recognize the vulnerable frame that the patient may be in on transition from hospital to home. They are still potentially sick, having symptoms of an exacerbation, and vulnerable to a repeat flare or a bounce back. Acute care visit usually represents a failure of asthma management. That's not to mean it's anyone's fault. That's not the intent here, but really it's an opportunity to identify gaps in care or where we could have improved management, specifically to avoid a subsequent severe exacerbation. Now, this time frame of 2 to 7 days aligns with another quality standard that was published called Transitions Between Hospital and Home. And what we would recommend should happen at this assessment is identification of the cause or trigger, a review of asthma control, change of medications if needed, a review of the asthma action plan and updating it if needed, and reinforcement of adherence, technique, and avoidance of triggers. Now, this assessment need not be in person. And of course, these standards and statements were developed pre-pandemic. And of course, we all know virtual care is certainly a very good option in many cases as a way to engage with patients and provide care. Now, in addition to the quality statements as well, there has been published some supporting materials, including a patient guide and implementation tools. So this is what the patient guide for childhood asthma looks like, and it's designed to give information on what quality care looks like and serves as a tool for patients to use during their primary care visits to advocate for quality care. There are also some implementation tools, so a guide on how to start implementing quality standards into practice. And there's also an online community that provides shared information and knowledge translation solutions for implementing quality standards into practice. So to summarize, what are our take-home points? Ontario Health and the Asthma Quality Standards Advisory Committee have developed 6 statements to reflect quality in asthma care for children and adolescents and adults in the primary care setting. These statements are evidence-informed with wide stakeholder input and employed a rigorous process in their development. Alongside, there have been published a patient guide and implementation tools. So really, I would ask all of you, as you come away from this presentation, to think about ways to incorporate these quality standards and statements into your own practice. With that, I'd like to thank you for your attention and acknowledge the Quality Standards team at Ontario Health, the members of the Quality Standards Advisory Committee, members of the public who provided valuable feedback as these are being developed, certainly the Lung Health Foundation for all of your support, and the Provider Education Program for inviting me to speak today. Thank you very much.
Thank you very much, Dr. Radhakrishnan. This was wonderful. So we do have a couple of questions in our Q&A box. I don't know if you were able to see them.
Yes, I can see them, I think. Let me see if I can scroll up. Okay, I think this is the first one. I hope so. So someone has asked, when waiting for spirometry, a trial of medication is recommended. What class of medications are you referring to? Is this ICS-LABA, or how long would you recommend the trial be? So I'm certainly going to put on, this is an excellent question. Thank you very much. I'm going to put on my pediatric hat, and I'm actually going to borrow from preschoolers because we often do a trial of therapy in the preschool age group. And I would invite you to have a look, even if you don't manage a lot of preschoolers in your practice. There are some pearls in the Canadian Thoracic Society position statement for the diagnosis and management in preschoolers. And really the first trial of medication that I would recommend in the age group specifically of 1 to 15 is a low dose daily inhaled corticosteroid. So choose your inhaled steroid of choice. Identify what would be considered low dose for the age group that you are speaking to. And actually, if you're, maybe let me backtrack for a moment. If you're truly trying to diagnose asthma, you may need to use a medium dose. So I'd, again, refer you to the CTS position statement to look at what dose to use. And it really should be daily for a minimum of 6 weeks, and ideally 3 months really, because most children are exacerbated when exposed to viruses. And unless they have a cold or two during the trial period, it will be difficult to recognize whether they've had a response to the trial of therapy or not. So I hope that answers the question, but I'll be happy to answer a follow-up if you type it into the chat. There's another interesting question. Why did pathophysiology and action of medications not make the list of self-management education? So that's an excellent question. If you read into the detail of the quality standard itself around that statement, I believe there is a little bit of information provided around asthma pathophysiology and action of medications, but it really was, I mean, I hate to say it, we sometimes have to be concise in order to maintain the attention of our readership, right? But there are lots of references included. So for those who are interested, there are options to learn more about pathophysiology and medication action. But really, we have intended that asthma education be provided not just by anyone, but specifically by people who are knowledgeable. So for example, certified asthma educators, certified respiratory educators, physicians, nurse practitioners who really have taken an interest to learn. So the reason for this is then based on the level of understanding of the patient, the education can be tailored to meet their needs, all of which to promote an understanding of asthma, what it is, and how best to treatment and to empower the family and the patient. The next question here, so again, I hope that answers your question. The next question is, why was vaping not included? And this is an excellent one, and it all speaks to timing. So, you know, anytime a position statement goes out or a guideline or a standard, it is reflective of what's happening at that time. And all of these need updating. So at the time that we had developed these statements, this was early last year. So, you know, in the spring of 2019, certainly vaping existed. It was a concept, but the impact and importance of it in youth and in adults was not really well identified yet. So as further iterations and updates to these standards happen, things like vaping or different forms of, you know, inhalation of irritants may certainly get included at that point. We also didn't include much about marijuana, for example, and that's certainly very relevant given changes in legalization in Canada. So these things will require updating as time goes. There's been a comment included here. The Lanark Referral Lung Health Program has a Facebook page and a YouTube page, which includes videos from respiratory therapists and respiratory educators demonstrating how to properly use inhalers. So thank you. That's super valuable and helpful. I had mentioned the CHIO Asthma website, the Lung Health Foundation website, but depending on where a patient and family is from, it's nice for engagement to utilize resources that are local. Maybe they recognize people in the videos, for example, so that's very useful information. Thank you. Another question, can I comment on daily as well as occasional, so 1 time a week, exercise-induced asthma and use of a short-acting beta agonist versus an ICS LABA medication? Another excellent question. So if one were to follow the GINA recommendations for people in whom ICS LABA is indicated, so Health Canada approval, if I'm not mistaken, for most ICS LABA medications, specifically the ones with formoterol, so budesonide formoterol is really for 12 and older. So if that's the age group you're talking about, and ICS LABA is what GINA would recommend. Short-acting beta agonists, you know, it really depends on how you think about exercise-induced asthma. You know, is it simply a trigger, and if you're not exposed to the trigger, there's no longer inflammation in the lungs? To be honest, I think most would go the other way and think that probably in the setting of exercise-induced asthma, there may be inflammation present in the lungs all the time. So perhaps using a steroid medication is actually the right way to go. Again, there will be a more formal answer to this question, and I apologize for sort of pushing it down the road, but with publication of the CTS guideline, as I mentioned in November, I believe there'll be a much more rigorous evidence-based response to that question. So I do ask you to stay tuned for that. I've had a sneak preview, so I know these kinds of questions have been answered, but I don't want to give you any misinformation. I really do want to follow what's going to be coming out in terms of the official Canadian word on this. Next question. This is wonderful. Thanks for your interest, everyone. Should there be concern about long-term use of ICS, inhaled steroids, in the pediatric population, since they may be on this for extended periods? So this, again, all these questions are really wonderful and really important. So in childhood, it really depends on the dose of inhaled steroid that you're talking about. Low dose and probably even medium dose inhaled corticosteroids. And what I mean by low and medium actually depends on age group. So 6 and older, there's a certain doses that would fall into low and medium inhaled steroids, but under the age of 6, it's really half that. So different dose to categorize as low or medium. So I would ask you to go to the CTS guidelines to give you more detail on that, or if you want to ask me later, I do have some slides. I could perhaps, if you send your question to the Lung Health Foundation, I can share those slides out. But the side effects we're talking about are really local. So thrush in the mouth, possibly affecting dentition or the enamel on the teeth. And those risks are mitigated by rinsing the mouth out or asking the family to get the child to brush the teeth after every dose of medication, which coincides nicely with morning and nighttime, which is when our dental association recommends teeth should be brushed anyways. As far as other side effects, there's always a question about growth and height in specific. And we do have evidence now for individuals who have been on low-dose daily inhaled steroids from childhood and all the way through, that there is a change, at least in one longitudinal study through the Childhood Asthma Management Program, or the CAMP study, which showed that people who are on the inhaled steroids, on average, may have a reduction in their height in adulthood of about 1 centimeter, slightly more than 1 centimeter for girls, slightly less than 1 centimeter for boys. So I do talk to families about this potential side effect because they're going to ask about it and they're going to want to know, and I'd rather them have the correct information than read something that's inaccurate. So we're talking about on average 1 centimeter difference, but it's very important to monitor the child's growth because every child is different and how they may respond to the medication is different. Once you're going to higher doses of inhaled steroids, first of all, as per the quality statements, this would be an indication for referral to specialist care. So once a child is needing more than daily medium dose inhaled steroids, then we can start to be concerned about more systemic side effects. So specifically adrenal suppression, that's the one that we would most worry about in childhood. And I would recommend screening the child. So doing a morning serum cortisol test that's before 9 in the morning as a screening test for adrenal suppression about once a year for children who are on high dose daily inhaled steroids. Okay, I'm just scrolling along the questions here. I hope I don't miss any. Do I know if any feedback from CTS on the new GINA guidelines will be coming out soon? So hopefully I answered that question. The CTS guidelines specifically addressing issues raised in GINA about as needed budesonide formoterol, whether or not we should be using short-acting beta agonist as needed at all, will be included in the guideline that's being published most likely in November. So within the month, we should have more official information about that. Okay. Okay, so a question about from the context of pediatrics, for mild cases of asthma in preschoolers, is daily ICS formoterol now the recommended approach? What is your go-to ICS formoterol in the under 6 age group? So, spoiler alert, no, that is not going to be the recommendation. In Canada, ICS formoterol is actually not approved for children under the age of 12 even, and we are not advocating that ICS formoterol be used in the under 6 age group. What will most likely be coming out in the position statement is really what we've been doing for decades, which is daily inhaled corticosteroids. Most likely there will still be an option for as needed short-acting beta agonist, but this should be made much more clear in about a month. And the last question, second last question I have here. So I've mentioned challenges of available resources for performing spirometry. I'm aware that some pharmacists have gone through spirometry training and may be providing this service at the level of a community pharmacy. Am I aware of more availability and innovative ways to help patients access spirometry testing? So it's an excellent question. It's one that we discussed at quite a bit of length. What would we recommend to the province as options for improving access to spirometry? There are some detailed around licensing of places or clinics that can perform spirometry. And there's interesting, to my understanding, there are only a certain number of licenses that have been offered traditionally in the province, maybe on an annual basis. So these are potentially things that could be changed at the provincial level to improve access. So improve access to licensing for performing spirometry. The tricky thing about spirometry testing is quality control. So you really want people who know what they're doing, so have gone through some kind of training, and equipment that is up to date and gets calibrated. Like spirometry equipment technically is supposed to be calibrated every single day. And so these are bare minimums for ensuring high quality spirometry testing. If it's going to be performed in clinics outside of a hospital or a medical center. But beyond that, as of today, I don't know about any other tools that are accessible specifically to pediatrics. I mean, I could just throw it out there. I think our different smartphone providers are developing applications that you can blow into your cell phone, for example, and get some kind of a spirometry reading. But what the quality control on that remains to be seen. But I think over the next few years, there will be other options. And certainly in the context of the pandemic, there has been quite a bit of movement south of the border, in particular with the American Thoracic Society, trying to identify ways of doing portable spirometry that people can do much more readily in the community. I see another question here about leukotriene receptor antagonists as an add-on to low or medium dose inhaled steroids very often. Do I use this medication? So now I'm only speaking to my own personal practice, and it's not necessarily endorsed by CTS or the Lung Health Foundation. I do, certainly. I mean, it's a licensed and approved of medication up to a very young age group. So I would often trial leukotriene receptor antagonist in a younger population if the child is not responding well as a next step up or add-on therapy after medium dose inhaled steroids, sometimes even after low dose inhaled steroids in this age group. But I think the important thing about this class of medications, which we are realizing more and more as time goes on, is that there can be some neuropsychiatric side effects. So I do caution and warn families that they may see change in behavior of their child, and you know, to sort of do a trial of the medication while watching the behavior of the child carefully. And if they were to notice a change in behavior, so irritability, depressed mood, temper tantrums, that kind of thing, to actually stop the medication and then retry again after a week or two. These are typically reversible neuropsychiatric side effects, but they can be problematic for many children, and a side effect that we're not willing to live with. So yes, I use them, but with caution. Let's see here. So there's a question about what side effects do I usually review with families when prescribing ICS formoterol, and why is it only recommended for age 12? What are the main concerns in the younger age group? So this is an excellent question, and I chuckle because it speaks to something that we deal with in pediatrics all the time. There's generally lack of evidence, lack of rigorous studies with large numbers of patients for a lot of what we do. So we end up doing a lot of off-label use of medications, and ICS formoterol may end up being one of those types of medications. The main reason that I understand as to why this type of medication is only approved above the age of 12 by Health Canada is simply because we haven't studied it or hadn't studied it well enough under the age of 12 at the time it was being licensed for use in Canada. However, since that time, and it's been several years that it's been available for 12 and older, decade or more, there have been actually a number of additional studies done in younger age groups that have shown good safety. So this is actually the next recommendation at the CTS level to do another update to the guidelines that would specifically address ICS formoterol in the younger age groups, with an aim to perhaps open up the Health Canada indications for use of this type of medication. Personally, I have used these types of medications in children. Certainly, again, this is off-label, so just caveat by saying that, but certainly children 6 and older with very good response in many of them. But again, my caution would be that these children need monitoring. So when starting younger children on these medications, I would see the child every 3 months to look for side effects. So tachycardia, tachyarrhythmia is theoretically possible. Sometimes children will describe abdominal pain, and I don't know if that's because they're experiencing tachycardia and it's translated in their bodies as an experience of abdominal pain. And then certainly looking at growth, this is really anecdotal, but whenever I have seen changes or reductions in growth velocity in children on inhaled steroids, it's often in children who are on inhaled steroid LABA combination medication. So I really monitor that carefully, particularly in the younger age group. Similarly, when we see adrenal suppression, it's typically in children who are on inhaled steroid plus LABA that we would see adrenal suppression. So I would again caution more frequent follow-up visits with these children, specifically looking for their growth, any side effects, and considering screening for adrenal suppression if you're going to be using the medications for more than 6 months at a time. So I'm scrolling further here. For people doing spirometry, I would also consider having regular, every 3 to 6 months, peer review of your spirometry you perform to continuously improve and provide high quality spirometry. Wow, that's an excellent suggestion. I love it. It's not something that had come up at our discussion tables, so I wish you would have provided that feedback, but I think that's an excellent concept. You know, this is partially currently addressed by this concept, as I mentioned, of licenses provided at the provincial level for a center to be designated as a spirometry facility. So built into that license is this concept of doing continuous quality improvement and quality assessment, including, calibrating the equipment and maintaining it properly, and those other, and having trained professionals perform the spirometry testing. But I do really like this idea. So for at the very least, for those who are listening, if you do provide spirometry, portable spirometry, especially within your clinics, to set up an option for review of the spirometry you're performing, and specifically to look at ways to maintain the quality of the spirometry testing that you provide, to make sure that it really is measuring the patients accurately. I see a question here that says, perhaps as an MDI, I suspect I was speaking about something, but I wonder if this individual is asking about budesonide formoterol. Is it available as an MDI, or is there some type of a medication of that nature? There is another medication that is available as an MDI that has formoterol as the long-acting beta agonist, and that's mometasone formoterol. I will mention it as trade name Zenhale, just so that people are familiar. I'm not advocating for its use, nor am I cautioning against its use, just to let you know that it is a medication that's out there. It comes as an MDI form. It comes in a few different doses, and I have used this medication at times in children as well. It would be used with a valved holding chamber, of course, just to optimize medication delivery into the lungs, but it is an option out there. I see another question here. We have a couple more minutes. For a child who is diagnosed with asthma under age 6, as per the CTS algorithm, I'm assuming it's recommended to confirm that diagnosis with spirometry once they get to age 6. Excellent question. We actually did not address this within the CTS position statement. I was a co-author on it, and it's not something we thought about. We were really having tunnel vision, I guess, on our younger children. But this has come up again at the CTS level, talking about, it sounds funny, de-diagnosing or removing a diagnosis of asthma from children who were diagnosed in the preschool age group. And this would be part of it, to repeat spirometry or do the spirometry once a child gets to age 6 to confirm that they, first of all truly have asthma, or to look and see whether they may have outgrown their asthma, because we do know that 30 to 50% of children diagnosed in the preschool age group will truly outgrow their symptoms and may no longer have asthma. So that's an excellent suggestion.
Okay, thank you so much, Dr. Radhakrishnan. I think we are running out of time. We are fortunate enough to have Dr. Radhakrishnan presenting for us again during this webinar series, and it's going to be on November 18th, and we're going to go a little bit more in depth on the GINA guidelines and how it applies to our pediatric population. So, so I want to thank you one more time. Great presentation. Thank you so much for answering all our questions so nicely and thoroughly. And again, a quick reminder, next Wednesday, the same time at 12 o'clock, we're also going to have a wonderful presentation by Dr. Tom Kovesi, also of CHIO, on smokes and vapors in youth. And I hope to see you all there, and have a wonderful afternoon, everybody.
Thanks very much, Lana, and thank you all for your attention. And yes, please do stay or join in again for Dr. Kovesi's talk and mine later on next month. And hopefully I'll have some more answers to these excellent questions that you've posed today.